Welcome to Respiratory Care Pediatrics. We're going to talk about the examination and assessment of the pediatric patient. You can find this in Walsh, Chapter 4. The healthcare team of a pediatric patient is numerous. There are physicians, nurses, respiratory therapists, speech pathologists, physical and occupational therapists, just to name a few. You've now become part of the healthcare team. Unlike babies, children present with previous history, and despite numerous advances in laboratory testing, the ability to obtain a pediatric history remains essential to the practice of pediatric respiratory care. In most encounters with children with respiratory conditions, the history provides the necessary information for the respiratory therapist to make a differential diagnosis and to suggest additional evaluations and management. The clinician should spend considerable effort enhancing their history-taking skills. The history for a new patient can be divided into the following categories: chief complaint or primary concern, history of present illness, medical history, review of symptoms, family history, and social and environmental history. Let's talk about chief complaint first. The chief complaint is the reason the child presents for health care. The chief complaint may simply be a sign or a symptom observed by the child or the caregivers and in need of further evaluation, such as shortness of breath. The chief complaint may also be a specific established diagnosis, as in the case of a child admitted to the hospital for treatment of acute asthma or a pulmonary exacerbation of cystic fibrosis. For a new patient, the initial step is to establish the chief complaint or primary concern. Additional information in the form of medical history is then found to further clarify findings that point either to a specific diagnosis or a set of diagnoses, differential diagnosis, that then leads to further evaluation. For the new patient, the medical history consists of specific components including history of present illness, medical history, review of symptoms, family history, and social and environmental histories. The important components of a history of present illness include how long or duration it's been going on, how severe it is, improvement or deterioration of symptoms, and knowledge of the following may help point to a specific disease or narrow the differential diagnosis: trigger of symptoms, aggravating or alleviating factors, medications that have been used or currently are in use, and whether these have been helpful, how chronicity, so how often or how long this has been going on, recurrence or seasonality of symptoms, review of the current medications, including non-prescription and alternative medications dosing, when and how taken, as well as what medications are taken for which symptoms may provide useful information. Part of the family and social and environmental histories are where the child lives, adult visitors from areas of endemic tuberculosis, and recent travel history may also suggest unexpected exposures or disease. For follow-up or established patient history, the medical history isn't as usually focused on developing differential diagnosis or establishing a specific diagnosis, but instead on determining current lung health and whether there have been any changes since the last visit. In this situation, the medical history simply consists of an interim history, a review of the key components of the medical history, the symptoms, and social and environmental histories. Questions are directed towards determining whether there are any interim respiratory infections or exposures, and whether these have triggered an exacerbation of the primary disease. Exposure to environmental tobacco smoke should be asked about specifically. And if an exacerbation of the primary disease occurs, it's important to determine whether this exacerbation led to a clinic visit, an emergency room visit, hospitalization, or whether the caregivers were able to manage the exacerbation at home. Information concerning the presence or absence of allergic, nasal, respiratory, gastrointestinal symptoms is sought. If symptoms persist, the examiner should try to figure out whether they are better or worse than at the previous visit and whether new symptoms are presenting and if these are related to the primary disease. Quality of life issues should be explored, missing school and the inability to participate in normal daily and physical activities, or the caregiver missing work because of an increase in the child's respiratory system, may suggest that disease management is less than optimal. Review of the current medications, including non-prescription and alternative medications, dosing when, how, and where taken, and what the medications have been taken for, and whether there have been any changes in the medication is vital. Adherence with and understanding of a treatment plan also should be explored. Changes in school and family situations, exposure to environmental tobacco smoke, allergens, and airway irritants, as well as recent travel or exposure to sick adults, may give clues to any change in the status of the primary disease. Is your sister sick? Are there any other people in the household sick? Optimal control of the primary disease may not be forthcoming, and then a more detailed history similar to the initial medical history may be necessary. Let's go over the pulmonary examination. It starts with inspection. Inspection includes asking about both pulmonary and non-pulmonary signs of respiratory distress. We'll start with non-pulmonary signs of respiratory distress. These include anxiety, fussiness, depressed level of consciousness, tachycardia. This is a typical anxiety scale for children. You can see that they can simply point, or you can look at facial expressions to see if they're sad, angry, happy, joyful, worried, or scared. One way to assess for level of consciousness is using the AVPU method, or Alert Voice Pain Unresponsive method. In a child, to be considered alert, the child is active and responds appropriately to the significant other and other external stimuli. For voice, the child responds only when his or her name is called. For pain, the child responds only when painful stimuli is received, such as pinching the nail bed. And to be considered unresponsive, there's no response at all. Next, we'll consider the pulmonary signs of respiratory distress. First, we're going to talk about tachypnea, or rapid respiratory rate. Rapid respiratory rate is seen in small children, especially when they have a fever. The higher the fever, the higher the respiratory rate. Once the fever is treated, if the child doesn't have underlying lung disease, then the increased respiratory rate should go away. However, in a child with underlying pulmonary disease, tachypnea may be a sign of respiratory distress, as well as breathlessness or shortness of breath. Breathlessness and shortness of breath can lead to head bobbing, grunting, nasal flaring, retractions, and eventually to desaturation and cyanosis if it continues. Let's talk about head bobbing. Head bobbing happens in response to the sternocleidomastoids, or neck muscles that serve to flex and rotate the head, try to overcome decreased lung compliance or increased air resistance, or both. The sternocleidomastoids contract during inspiration, and this pulls the head down and the clavicles and rib cage up. This results in head bobbing that happens in synchrony with each inspiration. You may also see retractions. Retractions are common signs of respiratory distress in both younger and older children and may be related to significant airway obstruction, lung disease, or both. Retractions result from the pulling in of the skin between and below the ribs, above the sternum, in the suprasternal notch, or both, because of significant airway obstruction and lung disease. This is a picture of subcostal and substernal retractions. When you have airway obstruction, it can result in a pulling inward of the lower costal margins. The abdominal is protruding, pictured in 1, and the substernal notch, pictured in 2. Seesaw movement of the chest and stomach is also present. The chest goes out, the stomach goes in, the stomach goes out, the chest goes in. This shouldn't happen. There should be smooth motion of the chest and abdomen together. This is a picture of suprasternal retractions. Soft tissue in the suprasternal space is retracted because of high negative pressure, most often caused by a patient's attempt to breathe against an airway obstruction. Palpitation. Palpitation of the chest wall and neck can be helpful in the physical examination of a child with respiratory disease. In infants and young children, palpitation of the chest during quiet breathing may elicit rhonchial or bronchial fremitus, which are vibrations of the chest resulting from the movement of air through the airways partially obstructed by mucus. In older children, palpitation of the chest during normal speech may elicit tactile fremitus. Tactile fremitus are vibrations of the chest produced by a spoken voice. Tactile fremitus may also be increased over areas of the chest wall corresponding to an underlying pulmonary consolidation. In an older child, assessment of the chest wall excursion can be accomplished by placement of the examiner's hands on both sides of the thoracic spine, with the thumb towards the spine and observing the motion of the hands and the patient's rib during a deep breath. Palpitation of the anterior neck may be helpful in determining whether the trachea is midline. Shown in the picture is the technique for determining the tracheal position in an older child. Auscultation. Auscultation involves listening to the sounds of the heart, lungs, and the belly. Sometimes with ears alone, but mostly with a stethoscope for the respiratory therapist. Vesicular breath sounds, or normal breath sounds, during should have no outside sounds. However, many times we hear adventitious breath sounds or grunting. Grunting is end expiratory pressure that a small child may use to help pop open or auto-peep, help pop open the alveoli. This will raise the oxygen saturation briefly. Other adventitious breath sounds include stridor. Stridor is a high-pitched audible noise that can occur during inspiration or expiration. Inspiratory stridor occurs due to airway obstruction. This can happen from laryngomalacia, subglottal stenosis, and croup. Expiratory stridor suggests an intrathoracic central airway obstruction due to a mass or vascular compression of the trachea, tracheomalacia, and bronchiomalacia. Biphasic stridor, or stridor both inspiratory and expiratory, typically indicates a more severe degree of laryngeal or central airway obstruction and may be associated with signs of respiratory distress. To distinguish stridor from wheezing, the examiner should place the head of the stethoscope over the neck area. If the sound is louder over the neck than over the chest, then it is most likely the result of stridor rather than wheezing. Most modern terminology primarily uses the term wheezes for continuous sounds and crackles for discontinuous sounds. Continuous sounds typically last for at least a few seconds, whereas discontinuous sounds are very, very short. Wheezes can be further described as inspiratory, expiratory, monophonic, polyphonic, high-pitched, low-pitched, or musical. Musical wheezing or polyphonic high-pitched wheezing typically occurs in asthma, and as airway obstruction worsens, wheezes tend to progress from end expiratory to both expiratory and inspiratory. The term rhonchi or rhonchus suggests movement of air through large airways that are partially obstructed by mucus. You can remember this by saying rhonchi in the bronchi. This is usually associated with medium to large airway disease such as bronchitis. Non-pulmonary examination. Non-pulmonary examination looks at growth, assessment of growth. Is there poor growth, developmental delay, neurologic abnormalities, muscle weakness, serious ear infection, conjunctivitis, nasal crease, nasal secretions, edematous nasal mucosa. Are the tonsils big? Is there an abnormal heart rhythm or murmurs? Is there a prominent second heart sound? Is the abdomen soft or distended? Is it the right color? Is it too big? Is there any atopic dermatitis or urticaria or poor circulation or cyanosis? In the extremities, is there digital clubbing, edema, or arthritis? Different triggers that can cause asthma. As part of the history, these should be explored if a child is short of breath. The last thing we'll talk about is laboratory assessment. Laboratory assessment happens after the completion of the history and physical examination of the pediatric patient. Laboratory testing may be required for further diagnostic evaluation. It can also be useful in telling you how severe a disease is or assessing previous disease management. Are the medications working? Typically, diagnostic laboratory evaluation starts with non-invasive laboratory tests and moves to invasive laboratory tests in a stepwise progression. Non-invasive diagnostic studies that may be considered for a child with a respiratory condition include chest X-ray, pulmonary function testing, bronchial challenge testing or exercise testing with cold air or methcholine, sweat chloride analysis, complete blood count, and serum immunoglobulins such as IgG, IgA, IgM, and IgE. Also included in invasive laboratory assessment of a pulmonary patient are blood gas analysis, either an arterial, venous, or cap gas, allergy skin testing, tuberculosis testing, sputum cultures, CT, MRI, and overnight polysomnography. Chest X-ray is one of the least expensive, least invasive, and one of the most helpful in pulmonary disease of children. This is clear chest X-ray with a normal-sized heart and normal-sized lungs. You can see that the ribs are evenly spaced and the clavicles are level. In conclusion, a few things to remember. Grunting, nasal flaring, and retractions indicate respiratory distress. Examination of a pediatric patient may occur in the lap of a caregiver. A crying child is very difficult to examine. Head bobbing is a sign of respiratory distress in a small child or infant, and respiratory rate varies in pediatric patients with activity level and with age. It is still a sensitive indicator of the severity of underlying lung disease. Invasive tests should be done last for laboratory assessment. Non-invasive tests should be done first. I hope you enjoyed assessment and monitoring of the pediatric patient. Thank you for your time and attention.